Good afternoon, everyone. My name is Deborah Hodges, and welcome to Patient Safety Issues, Who is Keeping an Eye on Them. This is our webinar for today. I'm the Program Manager and Association Manager for the Institute of Medicine of Chicago. Today's agenda, we will have our welcome, then we'll have a brief announcement on some upcoming programs, go ahead with our very rich and robust presentation, and that'll be followed by a question and answer session, and then the final closing. So learning objectives today are for this webinar are understand the decline in key patient and resident quality and safety areas, plan for impending changes that will be supported by the government and payers, address the need to spread improvement learnings throughout care settings with all healthcare professionals. We will also highlight providers that are making changes and seeing improved outcomes of care. And we're going to identify the efforts being undertaken by the CMS to address the complex nursing home issues driving low quality. And finally, it'll state the importance and proven value of the engagement of patients, residents, families, and community members in looking at the safety in hospitals and nursing homes. We are very pleased to be able to welcome today Martin Haitley, who's the President and CEO of Project Patient Care, and Pat Merriweather Argus, who is the Executive Director of Project Patient Care. So we're very fortunate, as I mentioned, to have both of them with us today. Pat Merriweather Argus is the Executive Director of Project Patient Care, which is a nonprofit that brings together patients, families, and caregivers to improve patient care overall. In that role, she has led nationwide patient and family engagement initiatives with over 140,000 clinicians, as well as an 18-month project to bring patient concerns into diagnostic research. Marty Haitley is a patient safety advocate with a strong interest in the roles of patients and family members and the role that they play as co-creators in patient safety solutions. He currently serves as the president and CEO for Project Patient Care, the Chicagoland Safety and Quality Improvement Coalition, which is dedicated to using the voice of the patient to improve care. In 2021, he also co-founded Patients for Patient Safety US, a US branch of the World Health Organization's Patients for Patient Safety Network. If you don't know about IOMC, let me just briefly give you a few facts about us. The Institute of Medicine of Chicago is an independent nonprofit organization of distinguished leaders in the health field who collaborate together to improve that public health. Drawing upon diverse membership with other regional leaders, IOMC addresses critical health issues through interdisciplinary approaches that greatly involve education, research, and communication of trusted information along with community engagement. We are a 501c3 nonprofit organization. Before we begin our program, we're going to do a little shameless promotion here. We have a upcoming event coming on June 22nd. This is our annual meeting and also Healthcare Awards. It's our major fundraiser for the year. We are very proud and pleased that the State Director of Public Health of Illinois is going to be our keynote speaker, Dr. Samir Vohra. So I hope that you will look at your calendar and join us for that event at Venue 610. It's an evening event. So at this time, what I want to do is turn the presentation over to Pat. And Pat, it's all yours at this point in time, you and Martin.
Thank you so much, Deborah. And thank you everyone for joining us either live or on a recording. On the next slide, you'll see that we really value the importance of patient safety. And the pandemic did put a big hit on some of the efforts that were going on. And now we're back to trying to reinvigorate those efforts. You see that the New England Journal of Medicine, CMS and CDC came together and they worked on this article highlighting that many of the infections or conditions that had improved really took a dive during the pandemic. On the next slide, you'll see that what happened during COVID, and this is documentation from CDC's National Healthcare Safety Network, as well as from CMS and other resources that show that declines in the improvements, such as in the CLABSI, some of the CAUTIs, and as well as MRSA. And that was also highlighted this past week by the Leapfrog group that documented the same thing, that these changes had occurred, the negative changes had occurred, and they highlighted the providers and states in which it really took a significant hit and the worst performing in those areas. On the next slide, you'll see also that in talking about what had happened before, there was great improvement that was occurring in infections and patient safety monitoring of adverse events. Changes had really been occurring, and unfortunately, we've reversed many of those changes. On the next slide, you'll see that some of the improvements, there were some that persisted, that again, the preventable adverse events and admissions with a serious preventable adverse events, but also things that, like I said before, CLABSI and CAUTI and MRSA, that increased during this time period. We know there were many challenges during the pandemic, but again, keeping in mind the focus on the patient, that oftentimes the patients suffered because of the resources devoted to the pandemic. On the next slide, you'll see that safety is not equal across all communities. So for race and ethnicity, we find that the safety issues are not widely distributed, equally distributed, and that there are inequities that have occurred. And equally known is that the patients know that as well. So again, the patients and communities know where disparities have occurred, and they continue to occur. On the next slide, you'll see that, yes, we had challenges in healthcare before, and we still have challenges. Staffing shortages, the pandemic brought on a reduction in the number of infection prevention and control professionals. That we have seen not only in hospitals, but nursing homes across the board, is people are not going into infection prevention and control as they did before. So again, that's an area that we desperately need staffing in. And then the patient and family advisory councils, many of them were suspended during COVID. Some met via virtual Zoom, but the voice, we lost many of the voices of the patients and residents and families and community members during COVID. So again, that's a setback as well in terms of the advancement of patient-centered care. And we know that many patients right now are more complex because they had to wait for treatment. And so that's another challenge that we're facing. But with challenges come opportunities. And I'm now going to turn it over to Marty, who's going to be talking about some of the advancements we have in patient safety going forward.
Thank you, Pat. And hello, everybody. It's great to be with you today. I want to start by just highlighting something that happened this week, which Pat's already mentioned, the Leapfrog Group, which is an organization that grades hospitals for their safety. It's completely focused on safety. They gave an A this week to a hospital that had previously been in trouble with Leapfrog. This is St. Bernard Hospital in Inglewood. They had 2 Fs on the Leapfrog report card in 2020, and they went from an F to a C to a B to an A as of May 2nd. And Pat Merriweather, who is with us today, is the chairman of their board of directors. I just wanted to take this opportunity to congratulate Pat, the leadership there, and frankly, the entire staff and community that has really come together to earn this A. It's a stunning turnaround, and I just think they deserve our acknowledgement, Pat, and my gratitude for your leadership there, along with a great team that you've got there. So it also shows that we can make progress when we prioritize it at the governance level, at the leadership level, and then really engage our entire staff with a focus on safety. Next slide, please, Deborah. So I'm here to talk about really what I'm doing, and Pat and I work very, very close together. We're partners at Project Patient Care, but I've also been very engaged in an effort, a grassroots effort, led by patient advocates. And these are mostly people who have suffered some kind of preventable harm, usually something very traumatic to themselves or to their families, and have been active for a long time in patient safety work, national transformation work in this area. And we became very disappointed during COVID, but not just because of COVID. Really, I mean, I'm sure there's a mix of people who lean Democrat or lean Republican on this phone call, but the fact of the matter is that patient safety was a huge priority for the Obama administration. They invested a lot of money in it. They invested in a number of demonstration projects, some of which happened here in Chicago. The results that Pat showed you about the progress that was made really is attributable to the way in which they engaged almost every hospital in the country to be focused on reducing 10 hospital-acquired conditions, infections, pressure ulcers, ventilator-assisted pneumonias, those things that we knew we had bundles for, and they wanted to get the entire country to work on it. And that just wasn't a priority for the Trump administration. So COVID, yes, did cause harm, but the change in administration, the change in investment in patient safety in this country also created a kind of drift from organizations prioritizing it. We take our signals from, frankly, what CMS is prioritizing and what they're paying for. And we just didn't see that kind of leadership in the Trump administration. So there was drift. And this group of people, 10 of us, got together in 2020 when we saw no mention of patient safety in the Secretary of Health and Human Services strategic plan, when we saw the National Quality Forum's strategic plan framed with a paragraph that said, we've spent too much time on safety and quality at the expense of equity and other things. It's time for us to move there. And we got very, very alarmed by the fact that that equity was being put in sort of a competitive posture with patient safety, when frankly, they're two sides of the same coin, and just the drift in patient safety. So we came together. Many of us had been partners in one way or another with different healthcare systems to try to improve care for the last 20 years. There's several Chicagoans here. I'm one. You'll see Beth Daly-Ullum, who has deep Chicago roots. She's the granddaughter of the first Mayor Daley. Sujin June, who works at Oak Street Health. Chicago is well represented here, and we came together to see what we could do to really get the administration to reprioritize patient safety. Next slide, please. One of the things that motivated us, I've mentioned a couple things already, the lack of attention at the government level, but there was also a big report that came out 2 years ago from the National Academy of Sciences. This was a 15-year look back at the progress of the PSO program that I know there are organizations probably on this phone call who participate in a PSO. And their assessment of the PSO program is that, one, we don't really know what's happening. The data is so controlled in silos there that we just don't know if any progress is being made. It's not showing up in the data, and it certainly hasn't become the national learning system that it was envisioned to be. So they put out a report essentially saying that we don't see any attention to patient safety being paid. And if we keep in this current trajectory, we are not going to be making future gains. So that was one of the kinds of documents that really alarmed us. Next slide, please, Deborah. I also just wanted to give you the most recent research. So Pat shared the really prominent piece from the New England Journal that leaders from CMS and CDC did. But there are 3 new reports here, 2 reports, one from David Bates and one from a group of people that are showing that limited progress that Pat mentioned, that show that we really haven't made the progress that we need to make. And these continue to get published, not not here, but recently, the Office of the Inspector General of CMS, looking at Medicare patients and their experience in hospitals and nursing homes, estimated that 25% of patients in both hospitals and long-term care facilities suffer preventable harm. So we still have a problem. We haven't made any progress that's been sustainable, even though we made progress when it was a priority for our government. We've got links to all these resources too. Next slide, please. Another prompt here is that this is not just a US problem. Patient safety has been a priority for the World Health Organization since 2003. And they saw the same drift and the same missing of milestones and missing of expected targets in other countries that we're seeing here. So they put out a big resolution in 2019 that called upon countries to say, look, we've learned a lot, mostly learning from failure, but we've learned a lot about what we need to do to make this work. And we're going to call upon all countries for the next 10 years to really prioritize patient safety. And we're going to measure progress. So WHO's got no ability to enforce anything. They've got no rules or regulatory mechanism, but they can track. And they're going to do a report card on every country that's a member of WHO and their work on patient safety every 2 years through 2030. And that came out of this resolution, which again kind of listed our continuing challenges, things that we've been working on for years, like it's not a top policy priority, which it was not during the Trump administration, but even really basic clinical things like hand hygiene and medicine safety and the competencies of the workforce, they listed as challenges. And then again, the things that they're going to be tracking for the next 10 years are kind of listed on the right-hand column here, but it's, make it a priority, support your staff, invest adequate resources, spread best practices, all the things that we've seen work and produce those results that Pat shared with you, but that we haven't seen get embedded and sustained and become durable. Patient and family engagement, which is, my special interest is here as well. Next slide, Deborah. There is a US action plan on patient safety too. And the fact that this exists, and I was on the committee that formed this plan, but the fact that this existed and wasn't included in those national strategy documents that I mentioned, including the Secretary's strategy for quality improvement, was alarming to us. So we're trying to really expand understanding and awareness that this action plan that was put out by IHI and HRQ after several years of work in 2020 is out there. It's got 4 key domains. One is culture and leadership. The second is patient and family engagement. The third is really making sure our workforce is safe. And the fourth is, having all of the organizations that are working in safety collaborate as part of a learning system. So it's a very good plan. What differs between this plan and the WHO plan, in my opinion, is that the WHO plan puts much more emphasis on federal or national leadership. This plan that came out of IHA HRQ is it's much more focused on the public-private partnership between agencies to some extent, but providers and then states. And it doesn't really call for the kind of national leadership that WHO calls for, but it's still a very, very strong plan, and I'm still a very strong supporter of it. And you have a link to it here. Next slide, please. So this is the WHO plan. I've kind of given you a sense of it already, but this came out of that resolution, and it has 7 tracks. The first is make it a national priority. The second is invest in high reliability operations. The third is do more QI kinds of things to really improve clinical processes. The fourth is engage patients and families. The fifth is support your healthcare workforce. Educate them to know their job and safety and quality, how their work impacts that, and then support them emotionally, safely in all aspects of their work. The sixth is using technology effectively. We have a lot of new tools that create the opportunity for better results. And the seventh is synergy, putting all these things together. They're kind of in their own lanes, but they all interact. And that's the essence of the WHO plan. This is a well-written document. It's dense, it's 100 pages long, but the wisdom of a lot of experience over the last 20 years in trying to make safety happen and get it embedded runs throughout this document. So for those of you that really want to dig deep into learning what we've learned so far, I can highly recommend this to you. Next slide, please. So one of the things that my group of patient advocates, Patients for Patient Safety US, did as soon as we came together is we started calling on the federal agencies that weren't prioritizing patient safety. And you see them in orange boxes here. And then we reached out to a number of organizations, mostly in the private sector, mostly in the nonprofit sector, but not all, to say, what can we do collaboratively to really get the attention of policymakers and stop the drift and reestablish patient safety as a priority. And what we found as advocates is that people turned to us and said, would you be willing to say certain things that we can't say? Would you be willing to say that we've lost the prioritization of patient safety? Would you be willing to even criticize the drift? And we were surprised by this because we're kind of used to people not welcoming criticism, but in a way, it is easier for the users of care to use our voices to highlight problems that you can't necessarily highlight when you're part of an organization. And so that was a very surprising thing that we did. And they prompted us to, next slide, please, Deborah, to publish an article that was, intentionally provocative and say, what happened? Who killed patient safety? It was a national priority with the Rose Garden ceremony by President Clinton back in 1999. It was a huge priority for the Obama administration. What happened to it, and why are we seeing the drift? And look at the results that we're seeing now because of that drift. So this paper, which was published in the Journal of Patient Safety and Risk Management, got a lot of attention and really propelled our work forward in those partnerships when it was published last year. Next slide, please. So here's what we're asking the federal government to really focus on, and that is, put in place new programs that really use tools that we know work. Patient and family engagement. If you don't bring the patient and family experience and insight into the work, you're going to miss input into some of the things that can work and make not only produce better outcomes, but produce better awareness amongst the public about our roles, frankly, in contributing to patient safety for our own self, for our patients and families, but also for the organizations that we turn to for treatment and also at the federal policymaking level. So we're kind of hitting that patient and family engagement piece at 3 different levels. As patients and families ourselves, feeding back our experience as patients and families to improvement work, and then looking at the areas where policy is made, whether that's at the organizational level or at the government level. And then transparency. A big reason why we saw those results out of the Obama administration was the fact that there was public reporting of what hospitals were doing, and to some extent clinical practices were doing on patient safety. And that kind of transparency generates competition and generates a will to improve and a learning from one another. So we are complete advocates for transparency. Accountability and oversight. Next slide, please, Deborah. This is when patients and families try to figure out who's in charge of patient safety in this country, this is what they see. The leader seems to be invisible. There are so many people that have an oar in the water on patient safety, and there's such a lack of coordination amongst the efforts that I think many of the providers listening to this today probably experience it as multiple demands, sometimes inconsistent for reporting or regulations that change from state to state or don't make sense. Patients and families experience this as we don't know where to go when we've had a preventable harm event. And, I as a lawyer, I can't help but observe that the reason we have as much litigation as we do is that that's where we push patients and families by not engaging them in other ways, by not giving them other ways to make their experience matter to them, to find out what really happened to them. We drive people to litigation. So there really is a need to have some visible place here for patient safety to have a home. Next slide, please, Deborah. Pat, I'm running a little bit long, so I'm going to kind of run through some slides quickly here to make sure we've got time for questions. This is a slide that was put together by the Jewish Healthcare Foundation in Pittsburgh, which is running a coalition to establish a National Patient Safety Board modeled after the National Transportation Safety Board. And it really depicts visually what I was just describing in words, and that is there is no central locus, no basic home for patient safety where all these different activities by all these different organizations are coordinated, or even if not coordinated, even just knowing what each other is doing. We have a complete patchwork quilt here of organizations that are trying to do things to improve safety and quality, but we don't have much coordination. And this, if you look at other countries that really have made improvement work, there's much more coordination than we have here. And part of that challenge is the excuse me, the break between our federal government and our states, which have a lot of power over regulating safety and healthcare in general. And the beauty of a National Patient Safety Board is it's not regulatory. It's an organization that focuses on analytics and investigation and makes recommendations to anybody. And most of their recommendations, frankly, go to regulators about what they're doing wrong or could be doing better or are doing too much of. So it could fill a really well-needed sort of coordination role here. And we're champions of it amongst our coalition. Next slide, please. There's a breakdown here about what we're saying when we talk to leaders. So my group of patients just presented at CMS in a couple of different sessions. CMS's Big Quality Conference was this week, if any of you attended. But really on the accountability and oversight piece, we're asking the government to reassert patient safety as a priority, to realize that when you focus on safety, you also close the health equity gap, because we're not talking about safety just for some patients, we're talking about safety for all patients, no matter what their socioeconomic status is, their insurance status, their educational level, their ethnic group, or their race. Patient safety and health equity are joined at the hip. We also want to see some sort of leader in patient safety. You know, it belongs, we think, naturally in the Department of Health and Human Services. And we also want to see the rules that are on the books enforced. If any of you have been following the story out of Vanderbilt about the nurse here that was convicted of manslaughter, frankly, for an error she made while treating a patient, there were a lot of things happening in that organization that were not in compliance with rules that exist. So one of the things that we can do to keep people like that nurse being served up as the scapegoat is just enforce the rules that we've got. And that's what we're really calling upon the Department of Health and Human Services to do. Next slide, please. Oh, these are all the members of the coalition. I didn't mean to put this slide in. I'm sorry, but you get a sense that this is the coalition that's really going after this National Patient Safety Board. We have legislation introduced last year. It hasn't gone anywhere because Congress is really not going anywhere so far this year. We hope to have hearings on it at some point in time. We are trying to attract a Republican sponsor. We had Republican sponsors all along as it was being developed. But after the last election, they all dropped off because this would probably involve an increase in federal spending. And that's one of the things that they're still working out how they're going to happen. We know we have champions on the Republican side of the aisle who are supportive of the concept. It's just the politics that are getting in the way at this point in time. Next slide, please. I mentioned the PSO report earlier, and this is a picture that in some ways we think reflects an opportunity for improvement of the PSOs. There are 90 or more PSOs in this country now that are perhaps doing wonderful work within their own PSOs, but they're not sharing that work. Part of the PSO plan was that the different PSOs would contribute their de-identified data to a national patient safety database. And so far, only 3 of more than 90 PSOs are contributing to that database. So we are calling upon the PSO community and frankly, the policy community to do what they can do to get the data out of the silos. So the PSO program really can be the national learning system that we hope it would be. Next slide, please. Oh, this is just a depiction of that National Patient Safety Database. This was part of the plan for PSOs from the beginning. It was the cornerstone of the national learning system that the PSOs were meant to be, but it really hasn't materialized because reporting to the National Patient Safety Database is voluntary. So we would like to see it incentivized or made mandatory, and that's one of the things we're asking policymakers to consider. Next slide, please. In terms of transparency, transparency is a big word. It covers a lot of ground. So we definitely want to see transparency in data reporting. And we're supportive of a series of metrics that CMS is putting into place to really get hospitals and nursing homes to report more about what they're doing on some of the key issues like maternal and child safety, the safety of seniors, health equity issues, and patient safety. But other parts of the transparency kind of bundle that we think are important is the way in which transparency fails when lawsuits are brought and settled. There really is no learning that comes out of medical liability claims right now because they're often sealed by gag clauses. So one of the things that we are asking the community to consider, and we're being a pushy partner on this, is settling cases in a way that allows the learning from those cases to be shared so that we don't see the same things happening in hospital after hospital after hospital when other hospitals have already learned from that particular lesson. Next slide, please. In terms of patient and family engagement, I wanted to share this slide. These are pictures of patient and family engagement that you can get by Googling, which I did, and they usually show patient and family engagement at the point of care. Next slide, please. Sometimes they show them at kind of the board level or the improvement team level. Next slide, please. And what we're doing now is really using patient and family engagement at the advocacy level, really contacting our policymakers saying, look, we're Americans, we care about this, we have families, we deserve a safe healthcare system, please help us get it. And again, what's been surprising to us is that we have been more or less embraced by CMS, by the Department of Health and Human Services, by a presidential advisory group to come in and really tell them what we want in terms of a safe healthcare system. And the things we're asking for are the things I've already talked about, as well as more investment. We want to see investment in patient safety from the federal government level, because that's what generated those results that Pat talked about earlier. Next slide, please. Patient and family engagement. Pat and I have quite a bit of experience building the infrastructure for this. Patient and family advisory councils, Pat already mentioned, getting patients and families involved in improvement teams where they actually can be co-creators. Pat's done a lot of work to get patients and families involved in research projects where they're not just focus group participants, but they're actually part of the research teams, sometimes even the teams that develop the research question. So there are a lot of opportunities for patient and family engagement as part of a bundle for further improvement work. Next slide, please. Finally, I want to just give you a sense of our progress so far. So in the upper left-hand corner here, there's a picture of President Biden. President Biden has a council of advisors on science and technology that has a patient safety working group. And they have put together a series of recommendations that are going to him right now. They're finalized. They are on his desk. We're expecting a report to be published in June. The language of that report is in the form of an executive order. Biden, perhaps more than any other president, understands healthcare because he's been such a engaged father in healthcare. I've heard him speak on cancer for over an hour without notes. He understands the system very, very well, and we're wondering if he may see an executive order as an opportunity to make some progress on patient safety as part of his legacy. CMS also has, and I think that we get some of the credit here for making some noise, and again, at their direction or at their invitation, but they've built patient and family engagement back into their strategic plan as a really important goal. And for the first time, they have essentially positioned zero preventable harm in healthcare as their goal. It's been a lot of debate. I'm sure many people here have been part of that about whether setting a goal that's that sort of idealistic serves our improvement work or detracts from it. I believe that setting any goal that's less than zero harm is too low. And it's great to see CMS embrace this. They are also working right now on a structural metric that will ask hospitals to report to them what they're doing on patient safety at a strategy level, at a leadership level, at a transparency level, and an improvement level. So we can expect CMS basically is in action is the message here, and we will expect to see more measures in the months to come. And then WHO, the National Patient Safety Board, I've already chatted a little bit about. I can share that legislation with you. You can also just get it by, it's called the National Patient Safety Board Act. You can Google it. It was introduced in December, and we expect it to be reintroduced this year. We know that the coalition is looking for a Republican sponsor because they want to present this as a bipartisan bill. That's the way it was developed. And finally, the World Health Organization, when they adopted that resolution and developed their action plan, also established a World Patient Safety Day, and that's September 17th. And my group of advocates has developed sort of a small march from the White House to the Capitol on World Patient Safety Day for the last 3 years. We're going to be doing it again this year. Every year has a theme. And the theme coming up on September 17th of this year is patient and family engagement. So it's right across the plate for us, and there'll be a lot of activity at WHO, but also in this country around patient and family engagement as we go forward. And Pat, I think that, Deborah, I think that's my last slide, but can we go forward? Oh, there's this. This is what I have mentioned, the structural metric that CMS is developing. They've put together a series of them in the last years, one on maternal and child health in 2020, this one on health equity last year, and the next one coming out is patient safety. And they have these domains where they ask organizational leaders to attest to what they're doing. And we think this is a good example of what we should expect to see for the patient safety metric. This is the health equity metric. So they want to see health equity being built into strategy. They want to see data being collected, data being analyzed, and data being used in improvement work with board oversight. So, and these are just a series of questions that hospitals will answer about whether or not they're doing these things, and their answers will be publicly reported. So again, it's part of that CMS strategy, not to use its conditions of participation as its lever, but to use its public reporting as a lever to try to motivate organizations to adopt best practices. Next slide, please. Our commitment as patient advocates is to work in partnership. I think you've got a sense that we can be pushy partners, but we know we can only do this by working with our dedicated leaders in the healthcare sector, as well as our government officials. So I hope this has been interesting. I think I've gone a little bit long, Pat, but I hope it's been interesting to our audience today. Pat, back to you.
Thank you, Marty. And actually, it's very exciting to see that the call to action. It's been a while since the first call to action took place on patient safety, and it's beyond time. Other countries, I think we've all seen that other countries are way ahead of where we are, and I have always felt that the patients and the patient advocates are the ones that have made some of the most substantial changes to processes and care outcomes. So again, nothing to take away from the clinicians, but it's those patients that do push and do know that there is another way of doing things. So thank you. And on the next slide, I think this is still Marty's slides.
Yeah, Pat, I'll address this. I meant to. So I think many people here are going to have familiarity with the Crossing the Quality Chasm report that came out in 2001, actually. Yeah. And it established those 6 aims for transformation in the 21st century: safety, effectiveness, accessibility, person-centeredness, efficiency, and equity. And we all know that. I mean, that's really part of what I think every organization involved in improvement work really thinks of as its aims. But what that report also did is say that we're not going to achieve these aims and hold on to them if we build them into organizations unless we have the outside environment supporting that. So they came up with this kind of diagram that has been lost along the way of, person at the center, microsystems, the people who are treating that person being focused on the patient, the organization supporting those people at the point of care, the clinicians who are actually treating patients, and then the overall society supporting the organizations with payment that incentivizes safety, a litigation system that makes sense. Ours is crazy. Education and regulation that support all of this. And that's where I think the real core of the problem is we try very hard within organizations to try to make safety happen, but we're in a headwind with media, litigation, regulations that don't make sense, a lack of education that just really has not done its part to kind of keep us reinforced. So we're making those arguments as well too. This is where we find really strong room for partnership with clinicians and organizations. So this is a diagram from that Crossing the Quality Chasm report, and I'm on a mission to make sure that we don't forget that second part of the mission, because we're not, just by focusing on the aims, we're not going to sustain it unless we have the right organizational infrastructure. Now back to you, Pat.
Okay. And I know that the discussion we've had has really focused on mostly hospital care, the settings of care, and the nursing homes are oftentimes the ones that where grievous outcomes are occurring on a daily basis, and right in our backyard in Chicago. So it's across the nation, but certainly Chicago and Illinois has also had a number of grievous situations. We can talk about staff shortages, but that also was pre-pandemic. Nursing homes, again, and there's a lot of reasons for this, that oftentimes they don't invest in their staff. There's a difference between the for-profit nursing homes and the investor-owned nursing homes versus the not-for-profits. And it's been documented, it's been studied that the not-for-profits have better outcomes of care, better satisfaction among the staff, less turnover, all of those things. And it's because of mission. And when we talk about, what is the mission of an organization? Is it just to, make money and bring money into the organization, to the shareholders? Or is it to really fulfill a mission of quality and safe care for those that are in a hospital or a nursing home as well? So with CMS, they also have, there was a requirement that, and this was great under the Obama administration, that all nursing homes had to have an infection professional, somebody that was working on prevention and control of infections in nursing homes. And that was to go in place by November of 2019. Now, just think about that. If every nursing home had had an infection prevention and control person in place, what a change that would have made in the outcomes. Because as we know with COVID, and again, this was rescinded by the Trump administration. It was one of the first things they did is they took that requirement away because the nursing homes protested, the for-profits protested. And as a result, nursing homes at the beginning, they were more than half of all of the deaths were in nursing homes. And they still continue to have deaths in nursing homes because we still don't have the infection and prevention and control persons in place. And I'll talk about what CMS has done to try and address that. And then there was a requirement for resident and family councils. In 2017, that was rescinded as well. And that had been out there for over a dozen years, that you had to have a resident or resident family council. Now, why this is important is because many of the for-profits don't even have a governing body within a nursing home. They may have a governing body that's hundreds of miles away, and they have no idea what's going on in the nursing homes, and there's no voice. So the importance of resident and family councils. Now, about half of the people in nursing homes don't have somebody that's in their community, a family member in their community. So we have suggested, and Illinois administrative rules provides for that a community member or a church group could serve as the oversight, as the council for a nursing home. So that's in our administrative rules. It was very well thought out, and this has been in place for years. So again, there's an opportunity to help the residents in the nursing homes. And the reason I say that is many are also in dementia or memory care units. And so their voice, somebody else sometimes needs to be their voice. On the next slide, you'll see this is some data that I pulled together, and this is from CMS. I went into their database. I was able to abstract information, and I just want to give you a perspective on Illinois, because it is important. And I hate to be a leader in this. I don't want to see Illinois as a leader for the bad reasons, but we have the most nursing homes with a red flag. A red flag on the nursing home care compare is a signal that abuse or neglect has occurred in the nursing home within the past year. So we have 15% of all the red hands in the nation in Illinois. So that translates to, if you're looking at Illinois, 1 out of 5 nursing homes. If you're looking for a nursing home, 1 out of 5 nursing homes have the red hand. And if you're in Chicago, it's 1 out of 3. So we have an opportunity to really make some changes. And I also wanted to give a perspective. You know, I talked about for-profit and not-for-profit, and really the voice of the residents and the families, and also, you know, what your mission is, what's your governance, what you're striving for as an entity. And this is across the nation. You know, 22.7% of all nursing homes are not-for-profit. In Illinois, we're just slightly below that at 22%. But then you go over next door to Iowa, and they have almost 40% that are not-for-profit. So again, there's some variations across the nation, but that does mean that there is a different perspective in nursing homes, and it is driven by, again, the mission and what their goals are. So we'd like to see advocates, and you'll find on some of the not-for-profits, they have resident and patient advocates on there as well, because remember, nursing homes provide short-term care and long-term care. Short-term care is under 100 days, and it's more medically oriented. Long-term care is 100 days or more. And then the voice of the resident and families. This has started to decline, and I expect it to be when they finally finalize all of their surveys for this year, that the resident and family councils will have gone down even more. That we'll have many nursing homes without any representation for the residents that live there. So again, there's some areas of opportunity. It's structural issues that need to be addressed. And CMS is working on some of those. But again, we need everything to be addressed to really save lives and make a difference in the lives of the nursing home residents. On the next slide, this is what CMS is doing. Now, for any nursing home with a high rate of infections, because, okay, if hospitals had increases in infections, believe me, the nursing homes had very high increases in infections. And again, a lack of PPE, lack of having an infection prevention and control person, and staff shortages, which make for sometimes shortcuts in delivering care and services. So CMS has, with the nursing homes with high infections, they have to do one of two things. They either have to hire a consultant with infection prevention and control experience and successful outcomes, or they have to require the QIO to come in and support them. Now, the QIOs are challenged because they don't have as many staff available to service all of Illinois or all of Chicago. So I think many are turning to hire consultants. The health inspections, now this is great on Nursing Home Care Compare. All of the health inspections will be out there. What happened in the past, and this has changed, it's a recent change, is that if a nursing home got fined or charged with certain, serious harm to a resident, they would appeal it. And sometimes the appeals were taking 2-3 years to be resolved. And that harm to that resident was never documented on the Nursing Home Care Compare site. Now the inspection reports are, and if it's under appeal, it will say it's under appeal, but people know if that red hand is at the nursing home, they'll know why there's a red hand there through the health inspection. The other part of this is, and again, this is complicated, and for those that work with nursing homes, you probably know this already, but the for-profit nursing homes have many subsidiaries. And what they do is almost every nursing home is owned by some large company or organization, or they're an LLC, so that the owner never has their hands, they never get penalized the way that an owner should. So CMS has required them to also identify all of their subsidiaries, companies, because oftentimes what they do is they own the building, and then they have the subsidiary that flies under the radar of CMS that runs the nursing home or provides the services. And sometimes they charge, they may own the building, but not the land. And so the landowner, who may be a friend, charges very high prices for the services being delivered. So again, it takes away from resident care. There's a whole history on this. On the next slide, you'll see that, again, these are some of the safety issues, the short and long stay issues. For hospitals, anyone that works in a hospital that is, transferring a patient to a nursing home for post-acute care needs to really look at Nursing Home Care Compare, and share that with the family members or the patient that is being transferred. Because some nursing homes, they divide the measures into short stay and long stay. And those measures really are eye-opening. When you see, antipsychotics or the drugs being given to residents at a high rate as soon as they get into the nursing home, again, that there's a lack of staffing. Usually they give them to keep them quiet as well as complacent. So again, it's important for hospitals to really be more proactive in this area. And we're trying to spread the word to consumers and patients. The bad thing about, when you have to make a decision about a nursing home is it's usually under great stress that somebody needs to go to a nursing home. And most times, most people never even think about looking at a nursing home for any type of care in the future. So again, there's a lot of information out there. One thing we also suggest is do not sign an arbitration agreement. That used to be a requirement for anyone going into a nursing home. The Obama administration got rid of that. It was a big issue because it required that there be no lawsuit against the nursing homes, that arbitration was required, and you had to follow the arbitrator's, final decision. So again, that you couldn't enter a nursing home unless you signed that. So that is gone. And we also tell people to look at that fine print, because they'll give you a lot of papers to sign, and you really need to read them or have a lawyer look at them as well. On the next slide, it's really just to let you know that there are initiatives taking place to address some of the issues going on. And certainly the violence in hospitals carries over to the violence in nursing homes. The ability to keep patients and families safe is really important, and to have their voice, the resident voice. And then the important thing I want to stress here is also engaging boards. Boards need to not be just focused on the dollars. They need to be focused on the quality and safety. That is their mission. And I urge anyone considering a nursing home to look at their mission statement and what it's about. Is it about the care and safety, and who's on their board? Because that'll tell you right away if you've got a bunch of investors on a board, where their focus is going to be. And on the next slide, this is just a reminder. We're hoping that someday that World Patient Safety Day also includes in nursing homes, or as they call them in other countries, care homes, in the discussions, because again, where great harm is occurring is oftentimes behind those four walls. There are some great nursing homes. Unfortunately, there's not as many great ones as there are ones that are not performing well.
We've got a quiet audience today, Pat, but maybe we'll just talk them to death. Let's see if there's any questions.
Pat, I'd like to ask either one of you, what should, I'll point this to myself as well. I have a mother who is in senior living and is thankfully in a very safe and wonderful place. But what should someone look at when they're looking at nursing homes or senior living, or is there a site, or how should they go about, doing some good due diligence?
Mm-hmm. I actually wrote a paper recently on this. And the things that you look at first, the red hand, don't even explore somebody that's got a red hand. The ownership, who are the owners? What's their mission? And again, I know that sounds unusual because you wouldn't do that for a hospital, but you have to do it for a nursing home. And then do they have a medical director? Who's the medical director? Sometimes they don't tell you who the medical director is or who the nurse administrator are. That's really critical because sometimes the medical directors serve on many different nursing homes. So they're never there to improve the quality and safety. And that is their role, is to improve the quality and safety. And then the measurements, is a short-term stay or long-term stay? And that really makes a difference because the measurements differ. And you can look at a nursing home and they're very good on short stay, but on the long stay, if you think that somebody's going to be in longer than 100 days, they may not be performing well, and vice versa. So again, there's a lot of information out there. It's how do you dissect it and really look into it. And I urge, it's always helpful to know if they have a resident or resident and family council, because that says to me that they're open to hearing communication and also asking if you can attend their next meeting. So you can see if it's just the administration talking about what's been done, or if the residents and families really have a voice at the table. So they do differ from nursing home to nursing home, the support that is provided by the administration and the listing. They are required under was under the old rules that they did have to respond to every request made, but not that they had to approve it, but they had to respond.
Okay. What we should do is get a copy of your paper or your article that you've written, and we can share that. We can also post it on the website, and then we can put that in the next newsletter of the Institute of Medicine of Chicago. So that way it'll be a nice complement to the video and of this webinar as a whole. So if you would be so generous in doing that, that would be wonderful. So thank you both. Good. Well, thank you both. Martin, do you have any other closing comments that you would like to make before we wrap up today?
Not really. No, thank you. It was great to work with you all. I learned a lot from Pat from her presentation, so that was great. And I hope this is useful to your members.
Oh, wonderful. Good. Well, thank you both for a very informative presentation. I know I learned a lot, and you've given us a lot of nice resources, links, and other things for people to go ahead and check and investigate going further. Just about everyone, on this call is going to have someone at some point in time who's going to be in nursing care, whether it's short-term or long-term or in a senior living center. And so these are good tips for all of us to have, especially checking on, like you said, the red hand or the red flags, definitely. So I just want to remind our attendees to please look at attending our 2023 Healthcare Awards and annual meeting on June 22nd. It'll be held at venue 610. Everyone is welcome, whether a fellow or an advocate or interested in learning more. We welcome you to attend that. So have a wonderful remainder of the day and a wonderful weekend, everyone. And if you want any other additional information on IOMC, please check the website at www.iomc.org. And you also will find us on LinkedIn, in YouTube, and Twitter. So have a good day, everyone. Take care.
And thank you, Deborah. Thank you.
Thank
And
you.
thank you, IOMC.